Hello, I am Jerónimo Farré, and I have prepared, together with Professor Hein Wellens, a series of videos on determinants of the electrocardiographic manifestations of acute coronary syndromes. In this first video, we discuss the role of the time between onset of symptoms and the documentation of the culprit lesion with a coronary arteriography. Acute coronary syndromes are usually produced by an acute atherothrombotic phenomenon initiated by a fracture or fissure in the protective fibrous cap of an atherosclerotic plaque. This results in the formation of an intraluminal thrombus, and depending upon the size of the thrombus, the patient will develop an unstable angina and the non-ST elevated myocardial infarction or an ST elevated myocardial infarction. In STEMI, there is a prolonged total occlusion of the lumen of an epicardial coronary artery. The five most important determinants of the electrocardiographic expression of an acute coronary syndrome are represented in this slide. First, we have the time between the occlusion of the coronary artery and the recording of the electrocardiogram. Second, the location of the coronary occlusion. Where is it located, in which artery, and at what level? Third, the severity of the occlusion, whether it's a total or subtotal occlusion. Fourth, the dominance pattern, that is to say, which is the coronary artery that provides the left posterior descending coronary artery, whether it's the right coronary artery, as it is usually the case, or the left circumflex artery, or whether it's a balanced pattern of circulation. And finally, the presence of collaterals that can in fact obscure the manifestation of a total occlusion of a coronary artery. There are some additional factors that contribute to the electrocardiographic expression of an acute coronary syndrome, such as the anatomic variants of the coronary tree, the presence of a previous myocardial infarction, or the concomitant existence of coronary artery disease in other vessels, or the coexistence in the same patient of more than one acute coronary event or an acute atherothrombotic event. In this video, we refer to the factor time in STEMI patients as a crucial determinant of the electrocardiographic expression of acute ST elevated myocardial infarction. Time is an important factor, and the time plays a role in two ways. First, the time between the onset of the coronary occlusion and the recording of the electrocardiogram. And the second, the time interval between the ECG registration and the coronary arteriography. This electrocardiogram was obtained from a 45-year-old male by the out-of-hospital emergency services, and you can see that it shows a typical acute inferior ST elevated myocardial infarction. In this case, you would expect a total occlusion of a proximal right coronary artery, because we have ST segment elevation in leads 2, 3 ABF and also in V4R in right precordial leads. In addition, there is ST segment depression in leads 1, ABL, and also from V1 to V3. This patient was brought to our hospital and underwent an urgent coronary arteriography showing a subtotal occlusion of the right coronary artery just before the takeoff level of the right ventricular acute marginal branch. Although we expected to find in this patient a total occlusion of a right coronary artery before important right ventricular branches, the vessel was not totally occluded. As we will explain in subsequent slides, the reason for this is the lapse of time between recording the electrocardiogram and performing the coronary arteriography. There are spontaneous and drug-induced factors promoting reperfusion in patients with STEMI. Thus, the Wood and co-workers in 1980 demonstrated that in STEMI patients the responsible coronary artery was totally occluded in 87% of them if the angiography was performed in less than 4 hours after the onset of symptoms. This proportion was reduced to 65% when the arteriography was obtained between 12 and 24 hours after the development of symptoms. This suggests a time-dependent trend to a spontaneous reperfusion. In addition, antiplatelet drugs, aspirin and clopidogrel, given at the site of first medical contact also contribute to a tendency to reperfusion. This is the electrocardiogram obtained in the catheterization laboratory immediately before the coronary arteriography. Notice that the ST segments are less elevated in this electrocardiogram than in the recording obtained at the site of first medical contact, and that the T waves begin to be inverted. This electrocardiographic pattern suggests a certain degree of reperfusion as shown in the coronary arteriography. The tendency to reperfusion by spontaneous factors and the addition of antiplatelet drugs explains that in STEMI, the electrocardiogram at the site of first medical contact may reflect signs of total coronary occlusion when sometimes the angiographic examination displays a subtotal or critical coronary stenosis. The reason for this is that the angiography is frequently performed 1 to 2 hours after the first medical contact and not rarely 4 to 6 hours after the onset of symptoms. We strongly recommend you to watch more videos on acute coronary syndromes in ECG Corner, and also to follow the rest of contents in our portal referring to this very important condition. Thank you very much for your attention.